يسعدنا جدا 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 ان احنا نلتقي باستاذ يعني رائع، تعرفت بيه منذ سنوات طويله جدا، وبقالي سنوات طويله جدا كمان ما شفتوش. ويعني هو شخصيه متميزه جدا، سواء في مجال طب الاطفال، طبعا معروف في مصر، معروف في الخليج جدا، له شعبيه طاغيه. وحاليا طبعا هو في امريكا، بعد عننا فيزيكالي، لكن ما زلنا متواصلين بيه. بروفيسور علاء دمرداش، هيز كلينيكال بروفيسور بيدياتريكس. اهلا وسهلا بحضرتك. He is a clinical professor of pediatrics at University of Nevada, Reno School of Medicine, attending neonatologist at UMC Children's Hospital of Nevada. He's a pediatrician and neonatologist. طبعا he's يعني achievements في النيوناتولوجي وفي في الكونتينوس اديوكيشن، وطبعا له ايادي بيضاء علينا وعلى جمعيه بورسعيد، يمكن مؤتمرنا الثالث والرابع وورش العمل اللي عملناها في دبي، وتواصلنا مع سيادته يعني افادنا الكثير.
الله يحفظك.
ولا ننسى ان هو شرفنا حتى في الحضانه في مستشفى النصر، ويعني عرفنا يعني ايه جرافيكس في الفنتليتور، وعمل معانا يوم مر معانا فيه. فكانت حقيقه طبعا بنشكر حضرتك، وانا سعيد جدا تواصلت حضرتك مره ثانيه. معانا طبعا الاخ الزميل دكتور ايفان عماد. دكتور ايفان طبعا من الشباب الصاعد الواعد النشيط جدا علميا، والمتميز جدا في كل اكتيفيتي بيشارك معانا فيه، وهو يعني محضر كيس برزنتيشن.
First of all, I would thank Dr. Osama Hussein for this chance and this very prestigious scientific committee. He gave me a very good chance to introduce this case scenario as an introduction to one of the most eminent neonatologists, Professor Alaa Eldermerdash. It's a great honor for me. Our case scenario today is a very simple case. It is straightforward. No tricky parts. It's very simple, and we are facing this scenario every day. I don't think so that any neonatologist have even one day in the NICU can solve this case scenario. But the aim of this case scenario is to order a mode of thinking, how to think and how to think in order and in correct way, and how to manage in the correct time. This is the aim of the scenario, but it's not tricky. It's very easy. So I hope you will enjoy this case. We have day 0. We have a preterm male infant, 32 gestational age. His weight is 1.8 kilogram. Admitted at NICU due to respiratory distress syndrome. He was born to a primary gravida mother who had preeclamptic toxemia. Premature rupture of membrane occurred 8 hours prior to delivery. No signs of maternal infection. So to summarize, we have a preterm born to a primary gravida mother, irrelevant any problems during pregnancy or delivery, apart from premature rupture of membrane 8 hours before delivery. So when we examine the baby, he showed desaturation with respiratory distress grade 2. Surfactant was given by Ensure technique and put on nasal CPAP. An UVC was inserted. Initial lab showed total leukocytic count 12, neutrophil 6%, hemoglobin 14, platelet 490, and CRP is negative. To summarize, preterm with respiratory distress, received Cervanta. Everything is smooth. He is not intubated. He is not on mechanical ventilation, just on nasal CPAP. So we have first question: start antibiotics or not? Someone will answer, I have CRP negative, baby is well, why I start? And this is not the mode of thinking we'd like. This slide is very important for everyone watching us to have a screenshot of this slide. It's very important to be in our cell phone all the time. We have 3 blocks or 3 categories. Red flag: if any one of these 6 red flags present, you will start antibiotics. Any 2 of the risk factor or clinical indicator, you will start antibiotics. So we have a preterm following spontaneous labor with respiratory distress. We have 2. So we will start antibiotics. We started antibiotics, baby on day 5. Culture showed no growth. CRP is negative. Baby is well. So we have a baby after 5 days of antibiotics. We reassess again, and the baby is well, no growth of culture, and CRP is negative. He's doing well, feeding is upgrading. Stop or not? This question is very important. في حد ممكن يقول خلينا prophylaxis، حد يقول no, the baby is well, no use for antibiotics. Guidelines say if we start antibiotic, you should review the antibiotic you start 36 hours after your start, as initial clinical suspicion of infection was not strong, with negative blood culture, and the baby is well, with no clinical indicators. Baby is well with no clinical indicators of possible infection, with CRP trends are reassuring, so we will stop antibiotics. So this baby, antibiotics are stopped. At this moment, the baby is hemodynamically stable on nasal CPAP. Feeding is upgrade. Again, we are on the 5th day. Okay, day 7 of age, after 2 days of stoppage of our antibiotics, the baby showed lethargy, evolving respiratory distress with frequent apneas, cold extremities, weak peripheral pulsation, capillary fill time for seconds, which is prolonged. EPG showed mixed metabolic and respiratory acidosis. Baby mechanically ventilated and received IV shock therapy with inotropes. To summarize, baby was previously well, doing very well after stopping of antibiotics with 2 days. At the 7th day, our preterm baby showed picture of shock and respiratory distress. So question number 3, what's the differential diagnosis for this deterioration? It is the second slide. I want every neonatologist hearing us today to screenshot this slide and preserve it on his or her cell phone all the time. The 5 differential diagnosis of deterioration of previously stable preterm baby. It's late onset sepsis or necrotizing enterocolitis or one of the ear leak syndromes or hemodynamic significant PDA or IVH. You will screen for every single of these 5 differential diagnoses. So for our baby, chest X-ray, proven no evidence of ear leak syndrome, echo study, no evidence of PDA, cranial ultrasound, no evidence of intraventricular hemorrhage. Necrotizing enterocolitis is less likely in the context of normal abdominal imaging and absence of GI symptom. So we have only sepsis. Another blood culture and septic marker was drawn with this results. CBC total oxide count 20 and neutrophil 80%, platelet 50, hemoglobin 12, and CRP 48. There is also toxic granulation in neutrophils. Blood culture, of course, is pending. Lumbar puncture is cancelled as the baby is hemodynamic significant and has thrombocytopenia. So we are facing a common presentation of case of late onset sepsis, but of mode of thinking how to reach this diagnosis and exclude the other is the important point of view. Which antibiotic to start? Guidelines say to start vancomycin and gentamicin, the agreement of NICE guidelines and the American guidelines. At day 12 with antibiotics, blood culture showed growth of negative staphylococci, which is a very common organism incriminated in late onset sepsis with sensitivity to vancomycin. So we will stop gentamicin. Baby is extubated and shifted to nasal CPAP. Inotropes also stopped due to hemodynamic improvement. So our baby is so stable after this 5 days of antibiotic shift. So when to stop? Guidelines say we can stop these antibiotics after about 7 to 10 days. So at day 15, we stop antibiotics. Baby now is vancomycin is stopped. Baby is off respiratory support. Has full of oral feeding. Trial for breastfeeding is successful. So baby is discharged home. Our mission is done and referred for visual and hearing assessment. This is the case. Before I end, I want this gold rule to be in the mind of everyone. is the art of neonatology lies in anticipation. It's not our mission to just treat preterm babies or newborn babies in NICUs. It's to anticipate the problems that can occur and take a step behind our baby. There is a common thing we can examples that can we mention if our baby receiving surfactant therapy due to respiratory stress syndrome. If you don't anticipating ear leak syndrome, your baby will go on pneumothorax or any ear leak syndrome. So you give surfactant, anticipating this surfactant will improve the lung compliance, will affect the pressure needed and time constant needed. So you will change your parameters, anticipating the child to have ear leak syndrome. So your baby will not have pneumothorax. You protect your baby by just anticipation. Our case always anticipation for sepsis. We have a preterm. We should anticipate that our baby can develop sepsis, so we can apply every step and very strict steps of infection control, so we can anticipate sepsis. So can we prevent it? So art of neonatology lies in anticipation. And thank you.
Okay. Thank you, Dr. Evan. I think it was a very good start, and Dr. Evan explained that this is a really common patient that we see in all neonatal units. So the question, and obviously congratulations, it's a great outcome that the baby went home, he was breastfeeding, so that's wonderful. However, can we improve on the care of the typical baby in the NICU? So I thought we'll talk a little bit about infection and see if one of the events that happened to the baby in the neonatal unit may not need to have happened. Could we save the baby some problems? Could we save the baby some infections? Could we save the baby some antibiotics? So we'll just go briefly over this and open the floor for discussion to see what it is that we can do better. So generally we start with definitions. However, this time I will start, what is the effect of antibiotics that we give to babies? Then we'll look at in definitions, some risk factors and some of the issues for treatment, prevention, and what can we do better. So the first is the among well-appearing term infants, early onset sepsis evaluation results in 4-fold increase in late initiation of breastfeeding. So this was a premature baby, so it's normal to take him to the NICU. However, the same ideas apply to term kids. So if mom had rupture of membrane or she had fever or the obstetrician said she has choreo, then we usually take the baby to the neonatal unit. Now I need some feedback from Dr. Evan and Dr. Osama. What do you do when you have a term baby whose mom has fever and then you take the baby for antibiotics? Does the mother come with the baby to the unit, or do you separate mother and baby? And what do you do? I'll finish the slide, then please tell me. Okay, so the second part is there is a 2-fold increase in giving formula, which follows if you're not really doing breastfeeding. And there are multiple studies now showing that in term babies, early antibiotics is associated with increased childhood obesity, gut microbiome changes, because we're giving antibiotics and it kills some organism. See the risks of early onset sepsis evaluation and treatment slide?
Yes.
Okay, good. So the idea from this that early antibiotics is not a benign thing to give to babies who don't need it. Obviously, if the baby needs antibiotics, the baby needs it. But however, if the baby does not need antibiotics, we have changes in the bacteria that's in the baby's body. Like all of us actually have more bacteria in our GI tract than we have cells in our bodies. So if we change them by giving antibiotics, that's not the normal way things should progress. Also, babies get more wheezing, more inflammatory bowel disease. So giving antibiotics is not a completely benign issue. Okay. In addition, there's each day of additional antibiotic therapy was associated with increase in late onset sepsis, necrotizing enterocolitis, and death. And this is from a study from 2018 in a large neonatal unit in babies less than 33 weeks. So what we found is that if you give babies lots of antibiotics in these small babies, you have increased incidence of late onset sepsis and you see death. And that's after adjusting for other problems with the babies. So the odds ratio is 1.24, which means you're 24% more likely to have all these problems than if you had not received antibiotics. So now we'll go through some definitions. So one of them is nosocomial infection. Now we call it HAI, or healthcare associated infection, or hospital acquired infection. So nosocomial infection or hospital acquired infection is the responsibility of the medical staff. Like if the baby comes to us from mom with a problem, we cannot really do much about that. So now we have the early onset sepsis, which is usually within the first 48 to 72 hours. And that's usually mom source of infection, whether it's a vaginal tract infection or is it a blood through hematologic spread through the placenta. Then there's late onset, which usually is the nosocomial type. And that will be something we can do things about. These are the common bacteria. We all have seen that. So the early is GBS, E. coli. We don't see Listeria much, but it's listed. And then the late onset is the coagulate negative staph, gram-negative organism, candida, yeast. Then late, then you have the multi-drug resistant organism, and these are a problematic things. These are pretty common problem. 34%, 36% of death in the neonatal period is associated with infection. So it's a major deal, and it's really important to do whatever we can to minimize the infection. Now, the longer you stay in the hospital, like your baby's typical, you had to intubate the baby. This baby was okay on CPAP. So now you intubated the baby, that will result in higher incidence of bronchopulmonary dysplasia. Definitely prolonged hospitalization because you stopped the feeding and you put them on vent, and then you had to start over again, feeding and weaning. And it results in delayed growth and development. Dr. Evan mentioned about some of the issues related to prematurity in particular. So that's a good case for it. Immature skin, impaired immunity are issues for preterm infants. And that's inherent. We cannot do much. Once the baby is born premature, he's with us. There's not much we can do about it. However, the extrinsic stuff, we can do something. So what did we do for this baby? We give him antibiotics for 5 days to start with. And we put UVC. You guys did excellent. You didn't intubate the baby. You just gave you surfactant with Ensure technique. That's great. So you can maybe tell us about the enteral feeds. H2 blockers like famotidine or Pepsid. Probably, I don't know about في مصر هل لسه في رانيتيدين ولا اتمنع؟ لأنه في أمريكا اتمنع الرانيتيدين.
Famotidine is used more widely now.
Yeah. هو المشكلة إن اتفضل دكتور.
stopped in Egypt and didn't return. So if it's found in pharmacies, it's very, very few amounts. But Ministry of Health prohibited it until get 100% sure it's safe. So it's stopped now.
Okay. لأن هو المشكلة إن manufacturing of ranitidine بيحطوا فيه substances that are not safe. فهم اتوقف في أمريكا. فده يعني الانتاسيدز اللي بتستعمل هنا دلوقتي يا إما بيبسيد يا إما proton pump inhibitors.
We do the same. Yes, we do the same.
Okay. طيب فيعني ممكن لو نعرف البيبي مثلا حط له UVC. How long do you keep the UVC? When you change fluids, how do you do the procedure of changing fluids and connecting your IV tubings to the UVC? These are important issues, and this is related to the organizational issues of the NICU, the space, the design, the nurses, how many are they? Are they trained? Workload? Are they going to do things the quick way or the one that is more meticulous? طبعا لو النيرس عندها 4-5 بيبيات حتى تشتغل أسرع من إن هي لو عندها مثلا 2 babies. فدي كلها حاجات we can change. The baby being premature, we cannot change. Typically for a smaller baby, usually less than 32 weeks, يعني مثلا 25, 26 weeks, they get infection, then they get capillary leak, then they have to be intubated and put arterial lines, more lines, then they get edematous and they go into respiratory failure, cardiovascular failure, and if they live, they have lots of problems afterwards. So we're trying to prevent that. Having premature rupture of membranes is a predisposing risk factor. Maternal fever is a risk factor. Together, they make things much worse. Obviously, sepsis rate is different from different places, from different countries. You need to see what your sepsis rate in your unit is, because the baseline is important in determining how you handle patients like that. لو نرجع للبيبي what's your policy? يعني what do you normally do for after you put a UVC? Do you put UVC in everybody, or do you put UVC in some babies, specific weight or specific condition, and how long do you leave it? لو ممكن تقول لنا دكتور أسامة يعني and it's probably typical of what happens in all other hospitals.
Dr. Evan.
If the baby anticipating to be sticky to our NICU for a long time, for more than 2 weeks, I think every baby will have a UVC or a decline. If he is anticipating to be of short duration, like 1 week, I think peripheral lines are more preferable in our NICUs.
Okay. And who puts the UVC, who puts the PIC, and who puts the peripheral IV?
UVC put by doctors, by neonatologists, and peripheral IV lines by nursing staff.
Okay, we pick
Big
lines.
line, big lines by neonatologist, by neonatologist.
Okay, and do you have TPN or you just do IV fluids?
Of course, TPN will be started if the baby is intubated also or expected to be a long time in NBO.
Okay, so for example, the baby you mentioned, would he get fed in the first or second or third day of life, like get breast milk? Or would
Yes.
you give him formula, or you wouldn't feed him for the first few days?
My baby, I will start as early as possible with expressed breast milk. At first 5 days of his life, he was on nasal CPAP. He was hemodynamic stable, so breastfeeding, which is rich with oligosaccharides, probiotic, prebiotics, will enhance the immunity. So I will start it and I will postpone TBN in this baby.
Okay. Does the mom come to the hospital, or she goes home, or what happens?
We depends on expressed breast milk.
No, what happened to the mother?
Yes, the
Is
mother.
she goes home in the next day, right?
Yes, yes.
Well,
Okay.
if you excuse me, it depends on the hospital itself, because we have a diversity of types of hospitals. There is obstetric and NICU hospital, then another hospital with NICUs without delivery. There is and so on. So it depends on the place itself, or the facility itself. The policy changed according to the place.
كويس. طب هل الأم مسموح لها تيجي تزور البيبي في اليونت ولا ما تقدرش تيجي للبيبي؟
She can, of course, she can.
Okay.
We have adopted this policy since a few years with a lot of obstacles from nursing.
Exactly, yeah. And as far as I know, it's really hard.
Yeah, it was hard, but since maybe 5 or 6 or 7 years, we adopted this policy. It's accepted now.
Great. طيب هل الأم بنديها مثلا breast pump to use أو bottles أو how did she bring milk for the baby?
Whatever the way she can. Sometimes we have a pump, and some units don't have. She use manual or the simple suction devices. It depends on the facility itself.
Okay. But hey, the point and احنا would see what is it that we do now, and is there simple ways to improve, and what we can learn from other people what they did. مثلا اليونت بتاعتكم moms can come and visit, and يعني as far as I know many of the units moms cannot visit. It's an issue. How does the mom pump or help her with bringing milk? Support الحاجات دي مش سهلة طبعا. So back to the baby. So there is, with a preterm labor and preterm rupture of membranes that happen with this baby, you have high risk for infection. And 15 to 25%, there is a maternal infection that predisposes or starts the preterm delivery process. This is reasons. So obviously with bacterial infection, there is increased prostaglandin in the amniotic fluid, and that stimulates the early labor. It can be ascending infection from the genital tract, or can be hemodynamic. and can be also coming from a body cavity, less likely, but this is can happen. So the nosocomial infection is the main thing. So I think we'll skip to go there because this is what we can do something about. So for example, this baby received 5 days of antibiotic. How long does it take your microbiology department to give you the result of the blood culture?
It also depends on the equipment available in the hospitals.
Exactly, yes.
Yes, some hospitals provide an initial result after 2 days. It's gram positive or gram negative. Some hospitals after 5 days.
Now, when can it
Unfortunately,
say negative blood culture, you can stop antibiotics?
Most of the hospitals after average 10 days to 14 days.
Well, exactly. So yeah. Okay. Do you also have term babies admitted to the unit with antibiotics because their mother had a fever or had a prolonged rupture of membrane?
The baby is well and is doing well with have his feeding well. He will not start antibiotic.
So
Only
term baby, mom has a fever, a rupture of membranes more than 18 hours. You wouldn't give antibiotic. You would just feed the baby.
yes.
Okay. In the United States هم بنعمل chorioamnionitis diagnosis is dependent on the obstetrician. يعني احنا criteria for chorioamnionitis is available, which is premature rupture of membranes, maternal fever, maternal leukocytosis, uterine tenderness, purulent discharge. The obstetrician does not have to apply all these criteria. If he says this mom has chorio, it's chorio. But we admit the babies, and في حاجة دلوقتي اسمها sepsis calculator for babies who are not symptomatic. They have no symptoms. We plug in the numbers for what are the risk factors and what's your baseline sepsis. So the less likely there is sepsis, the baby may not get antibiotics. But if you have high baseline sepsis rate, the baby will probably end up getting antibiotics. Well, if the mom has chorio, the baby has to be assessed and mostly admitted to the NICU and getting antibiotics. There is some separation. This is what we talked about in the beginning, that if you work up the baby for sepsis, you give him antibiotics, you separate him from mom because the baby has to get that in the neonatal units to be monitored, to be assessed, to make sure the IV is good. The quicker the blood culture results can come back, the less time the baby spends in the NICU away from the mother. فالحقيقة يعني أنا اللي أعرفه إن فعلا زي ما أنت قلت كده على حسب الميكروبيولوجي لاب بيعمل إيه. ممكن 5 أيام، ممكن 7 أيام، ممكن 12 يوم عشان الميكروبيولوجي يقول الكالتشر is negative. But this period of time you have to decide, do you give the baby antibiotics or do you just observe or do you send the baby home? Tough questions, and if anything bad happens to the baby, it's your responsibility. فالادفانسمنت اللي حصلت في مثلا في الدول الغربيه والدول الخليج حتى ان البروسيسنج اوف بلاد كلتشر دلوقتي في ميديا وفي اوتوميتد سيستم بحيث ان خلال 48 ساعه 98% of the organisms that are going to grow will be found. If you have a blood culture or you talk to your microbiology and get bottles for blood culture that will grow your organism in 48 hours, it will save the baby stay in the hospital. It will save money from antibiotics that you don't have to give. And you send the baby home to his mom sooner. It's investment, and you have to update your microbiology. You probably have to bring them blood culture bottles, media. هتبقى مكلفة، بس ممكن to save money on the other side. يعني لو انت مثلا عندك baby، طبعا these are to the asymptomatic baby. Your baby has to be admitted. It's a premature baby, 1.8 kilo, has respiratory distress. He needs to be admitted. But how long do you give him antibiotics? يعني if you have a blood culture that grows in 48 hours, then you don't need to give him for 5 days. So that saves money. It's less antibiotics. Also, if you don't need to give antibiotics, you may not need the line. If you give the baby some feed and he's tolerating the feeds, then you don't need your UVC. So it's worth thinking about. يعني ان انت to invest in microbiology وتوفر في ال NICU، لان المشكلة كمان في مصر ال NICU beds are not that much available. يعني I'm sure you get calls of parents, their baby needs ICU bed, NICU, and you cannot take them because you don't have beds. So this will allow you to take care of the babies who really need an ICU versus who someone does not need as much antibiotics. So back to the nosocomial infection, which is the responsibility of the medical team. So most commonly is Staphylococcus infection. And that's mostly associated with central lines. The nosocomial infection, or now they call it hospital-acquired infection. If it's associated with central lines, now it's in a category by itself. It's called CLEPSI, central line associated bloodstream infection. How do you minimize the chances? Okay, your baby had staph coagulase negative infection, correct?
Yes.
Okay, could that have been prevented? And then you also, after you got the infection, you had to intubate him, you had to stop the feeding, give him antibiotics for 7 days. So could we have prevented the staph infection?
Yeah, of course. I think first question we have to answer is this baby really need a central line or umbilical venous catheter or not? Then the moment we insert it, we should have a clear plan when to remove it and remove it in very short time, in the appropriate time. Every day we have lengthened the insertion of UVC. Will increase the risk of latent sepsis.
Good. So these are all great points. So not to put it in if you don't need it, and to remove it as soon as you don't need it that much anymore. However, meanwhile, he's getting fluid through the umbilical venous catheter. فدلوقتي في حاجة بيعملوا bundles، لأن مثلا كل حاجة من دول لوحدها كويسة. لما بنعمل حاجات كتيرة في نفس الوقت, you get a much better result. So it's a bundle of procedures that you do. So you think about, do I really need to insert it? Can I remove it safely today? But more importantly, how do you connect your fluids to the catheter? And this seems to be the main issue. فدلوقتي مثلا البندل دي it's available online, يعني it's not a secret. ازاي النيرسز، لان دي nursing procedure، ان هم ازاي connect your fluids to your line. انت هتدي antibiotics، الantibiotics دي هتديها through the line. فانت you have to disconnect the fluids, connect your antibiotics, give it, stop, remove, disconnect. this opening and closing and connecting, that all is a risk for infection. And that's most likely how the baby got the coag negative staph. Also, how clean is the site of the insertion of the catheter. مثلا مغطينه بدايبرز والدايبرز مليان urine and stool, ولا it's exposed and clean and we check it. سواء في umbilical catheter طبعا لو thick line انت you put the dressing بس برضو to check on the dressing, is it clean, is there blood, is it red. فدي البروسيس of handling central line دلوقتي بنسموها bundle of care. فده لما بنعمل حاجة زي كده بنقلل احتمالات infection from nosocomial, from us as the medical team. The timing of the infection, and usually it's the late infection problems. You've had all these with your baby: respiratory distress, temperature instability, abdominal distension or feeding intolerance, hypo or hyperglycemia. Then he becomes hypoperfused, tachycardic, have metabolic acidosis. When it gets severe, things are much worse. Luckily, your patient did not have that. And then they would do the evaluation just like exactly what you did. You will do the CBC. You will do check for left shift or immature to total ratio of neutrophils, X-rays, and blood culture, and PCR. Or if there is a specific organism you're looking for and it's hard to grow in a blood culture. Now, حتى staph epidermidis used to take a long time to grow. دلوقتي newer blood culture, within 48 hours, if it's there, it will grow. Even the fungal culture, احنا في neonatology بنبعت one culture, aerobic, anaerobic, and fungal, with about 1 ml of blood. طبعا the more blood you have, the more likely you'll grow the organism, بس يعني 1 ml is generally good. Adults, well, big people, they usually send 2 blood cultures. Criteria are a little different for neonatology. For 1 ml in 1 blood culture will grow whatever organisms that is there in the baby. IT ratio بنعملها كتير. CRP كويس ان بتعملوا ال CRP او however the cut point is important لان sensitivity and specificity of CRP for infection changes with what cut points do you take. The higher the number, it will be more specific and less sensitive. You probably can see how that helps, but the CRP goes up 12 to 24 hours after the infection. You may need to delay it a little bit, so it's more helpful for trending recovery rather than to start antibiotics or not. And start antibiotics or not, you need to decide once the baby becomes sick. For lumbar puncture, you brought up the issue, should we do lumbar puncture or not? In most places, when we start with the sepsis workup, we don't do lumbar puncture unless the kid presented with seizure. We can delay the lumbar puncture, but then you need to get a good one to look for cells. And if you're treating with antibiotics, you may not grow. But if you're looking for cells, if you have high white count, then you know there's meningitis, and then you need to adjust your treatment. You have to treat for longer. You have to you may need to make changes in your antibiotics. However, if you only have staph epi, generally it does not cause meningitis. When do you stop? So you start once you suspect, but when do you stop? So for gram positive, it's about 7 days. Gram negative, it's 7 to 10 days. And the sooner you stop, the better it is. فمثلا في places عندهم antibiotic stewardship program. لو انت ابتديت حاجة مثلا زي فانكو او سيفتازيديم او سيفاتوكسيم لازم infectious disease person follows up with you and make sure that you stop it when it's no longer needed. هل لسه في سيفاتوكسيم او كلافوران في مصر ولا برضه مش موجود؟
موجود يا فندم.
اوكي. هو الشركه اللي بتعمله هنا في امريكا بطلت تعمله، فبس ممكن طبعا في شركات في اوروبا او في كده. هو مش مضر يعني، بس الشركه قررت انها مش هتعمله يعني. طبعا انت كدكتور taking care of a baby who became sick, now he's better. You don't want to stop the antibiotics. You want to give it longer to make sure that the baby stays good. However, the right thing to do, because longer antibiotics is not good for the baby. You may have fungal infection later. You may, as we've mentioned, there is higher obesity. You're changing the bacteria that's normally in the baby. One of the issues about this microbiome is that in babies born by C-section, they don't have the same, healthy babies, they don't have the same bacteria in their GI tract that are babies born vaginally. It's an issue for how many babies are delivered by C-section. That's one of the criteria for hospitals to monitor the rate of their C-section. If their C-section rate is high, they have to look into it and see why they have a high C-section rate. So C-section rate of 10% is about average. 15% if you're in a high risk obstetric service. So if you have a rate of 25, 30%, you have to have a reason why you have so many C-sections. Then it's not good for the mom, it's not good for the baby. It's important to see what we're doing, even though the baby looks okay, mom is okay, but can we do better? So we've actually have gone through most of these issues. This is evaluation and management of possible neonatal sepsis of more than 35 weeks. This is available from the CDC. متهيألي ما اعرفش انتوا اكيد بتتابعوا كوفيد والCDC recommendations بتاعت امتى التست وكده، بس يعني CDC في امريكا حاجه كبيره. We دايما follow the recommendation of the CDC. فده it's a flow diagram. It looks busy, but it's easier to download it. الميزه ان حاجات CDC دي كلها free. يعني you just go on their website, you search what you want. So this is evaluation and measurement of possible neonatal sepsis, more than 35 weeks, and you can download this. So can we prevent infection? So this is over years in the United States, and you can see the rate of infections, it goes down. And that's because organizations are interested in this issue by the issue statements. Then the CDC comes up with guidelines. Then we practice these guidelines. So the infection rate goes down. So it's a preventable infection. We're not going to get to zero, but you can go from 1.5 to per 1,000 live birth to less than 1. So you can make a major impact. This is from McMaster in Canada. And what they did, they say, oh, our rates are high. they keep going up and down. Can we do something about it? So they form a team to look at how they can prevent infection in their NICU. And you can see over time. So it's not going to be magic. You're not going to say, okay, this is what we'll do, and everybody will be in compliance and will perform perfectly. It will take time, but it will come down. So that's the importance of thinking about this as a team effort. Nursing is very important, doctors, everybody who works in the NICU, how you clean the place, what's your policy for moms. So it has to be a new working group, a new team comes together and decide, okay, how are we going to decrease that? So your baby, you did wonderful for the baby, but the baby had an infection that she didn't have to get. So no third generation cephalosporin. You only treat sepsis, do not treat colonization. And shorter period of time, the least spectrum. You can skip this. So good antibiotic practice. So stop antibiotics if culture is negative. So the earlier you get the culture, the earlier you can stop your antibiotics. So I would think it's probably worth the investment. These are some excuses. So raised CRP, is it coming down? Contamination, and we don't have the result of the blood culture. So you're already doing this. This is some pictures of how a central line device can cause infection. It can introduce infection to the baby. So insert it only when needed, remove it when we can do without it. It doesn't have to be perfect. The baby doesn't have to be on full feeds. This baby is getting 100 ml per kilo per day. That's good enough. Sterile technique, minimize manipulation of the catheter. So this is a nursing important part, is that, okay, we have to give this baby this antibiotics. We have to start new fluids. So let's do it all at one time. So we clean everything, do it at once, and then leave it alone. Okay, so we can stop now. Prevention is important, and thank you for this presentation. I hope that some of the ideas we can use is to decrease late infection. Okay, thank you, Dr. Evan. Thank you, Dr. Osama, for the generous invitation. And if there's any questions we can answer that. Maybe Dr. Evan can tell us how frequent do you get staph epi infections, and do you keep track of how many infections you have in a month?
Nearly 2 to 3 patients of 10.
Okay, are they mostly associated with central lines?
Yes.
Oh, okay. Is it more recently or more before?
I think nowadays with the phobia of COVID, with more hand hygiene, hospital-acquired infections like staph epi more or less than before.
Okay, so that's kind of indirect evidence that actually hand hygiene is important, and that if you have a group that makes sure everybody's doing their hand hygiene and make it easy for people to do, like easy to access alcohol or water and things. Occasionally we have seen مثلا the NICU, the soap runs out, the sink is not working, this thing needs cleaning. But simple things can save antibiotics, which is expensive. Yeah, I'm sure vancomycin is expensive.
Of course.
So there are things that a team of people, doctors and nurses, can get together and do something, and that would help babies get less antibiotics and save money for the NICU. I'm sure Dr. Osama would be happy with that.
Yes, sure. I'm checking questions. Still didn't arrive any questions. Maybe we wait for a few minutes if someone's writing something. But actually, it's a very important topic, and we have almost every now and then the problem of central line. Actually, as I told you, there are various types of hospitals, hybrid hospitals. Even is working with me now in Nasr Hospital, but it's changed. Became a specialized children's hospital with post-operative for cardiosurgery and for orthopedic and for oncology and so on, anomalies, congenital anomalies for pediatric surgery. So we have different scope of cases we meet, and the scope of the hospital itself have changed completely. We don't see normal neonates or distressed neonates. I mean normal neonatal work, not normal neonates.
Common, not the common stuff.
Yes, they go to other places. So, but we are in contact, of course, and sometimes we meet such cases, but the scope is different. So we meet central line infections even more because we do it a lot. Surgeries need long time of TPN. Some cases needed, post-cardiac needed. So actually, we now see it more. Not a very frequent problem, but more susceptible to happen. Because in the old days of the usual neonatal care, we don't use a long time central line. We don't use umbilical catheter as a routine, although a center of two may adopt it as a routine, but we don't. We didn't approve it earlier, and now we use a central line different ways. Pick a few times central line, maybe the usual lines if we don't use simple flows, not TBN, but we see it and continue to see it. So this lecture is very important for us, and we'll keep it recorded for other questions.
شكرا دكتور أسامة على الاستضافة يعني، وإن شاء الله نشوفك in person كده بعد ما الكوفيد يخلص.
I hope.
شكرا دكتور إيفان.
شكرا دكتور.